Today's lecture will be the remote learning section of kinesiology, the spine part 1. The first part that we'll be talking about is just the general architecture of the spinal column. The first region that we'll begin to discuss would be the cervical region, which the region begins at C1 and ends at cervical spine C7. When we look at the curve, there's two ways to explain this. We could say that in the anterior position, the curve is more convex, or we can say in the posterior position that the curve has more of a concave shape. So concave in the posterior department and convex in the anterior department. The next section we'll be looking at will be the T1 through T12 section, which is the thoracic region. Again, when we look at the spinal curve, we could say two things: that the curve is concave anteriorly, or we could also say that the curve is convex in the posterior compartment. The next region would be the lumbar region, which is signified from L1 down to L5, where we see the connection of L5 to the top of the sacrum. This region, L1 through L5, again, when we draw out the curve of the spine, we could say that it has a convex curve in the anterior compartment, or also we could say that in the posterior compartment, the curve is facing more transverse, or the curve is more concave in the posterior department. We also see the fused section of the sacrum. Usually the sacrum has, again, the sacrum including the coccygeal region. So the sacrum is composed of 5 fused vertebrae. We can also say this is the posterior pelvic girdle. And when we're looking at the sacral region and the coccyx region, which is the coccyx region, can be anywhere from 3 to 5. Mostly it's 4 bones of the vertebral column of the coccyx. And this area, again, when we're looking at the curve, we can describe it in two ways. One, in the anterior position, the curve is facing more concave, or in the posterior position, it has more of a convex shape to it. So the first vertebrae that we'll be looking at within the vertebral column will be the C1 and C2. They're also referred to as the axis, or atlas and axis. So this first one would be C1. This would be considered to be the atlas. And the second one would be C2 would be considered to be the axis, or the second cervical vertebrae. And that's mostly often distinguishable by the protrusion called the dens. So when we're looking at specific landmarks, the first thing that we're going to notice about the cervical vertebrae is their size. So the cervical vertebrae features are going to be smaller, and as we move down to the lumbar region, uh, due to the lower back having to support the weight, we're going to see the same features that are going to increase in size. The first area that we should talk about is going to be the superior articular facets. These two articular facets, these are composed of hyaline cartilage, and these are what are going to articulate with the occipital condyle. So basically this is where the base of the skull sits. These articular fossa of the first vertebrae have about 20 degrees of capital flexion, which means just the simple tilting of the head or the skull, usually 20 degrees, and approximately 10 degrees of capital extension or extension of the head. These also contribute to the total flexion and extension of the neck also. This pair of joints, when we're talking about C1 connected to the base of the skull, is considered to be a craniovertebral joint. It also, again, consists of these condylar regions where we have the hyaline cartilage located, and the final piece in flexion lateral flexion is the skull has the ability to laterally flex on these two condyles in 5 degrees in both left and right lateral flexion. So some other key points that we see that the transverse processes here and here are going to be extremely small. And then the spinous process actually starts or begins in C2. So when we're looking at C2, we begin to see the spinous process begin. The vertebral foramen, you can notice that the vertebral foramen of C1 is slightly larger. This is where the brainstem is actually going to be sitting. So the end of the brainstem is called the medulla oblongata. And then in C2, we can see how the medulla oblongata is then going to narrow in the vertebral foramen, and we see the first sign of the vertebral spinal, or the vertebral spine entering into the vertebral foramen. So working down, when we get to the thoracic spine, we still have the key features of the spinous process, the transverse processes here. We still have the articular facets. So this articular facet and this one would fit into the inferior, or would sit into our, this is how the bones stack on top of each other, is through the superior articular facets. So T1 would stack on top of T2 and etc. But we also start to see the first distinguishing feature of the transverse costal facet. And costal simply means the rib. So I'll just draw it in here. The rib would be wrapping around, attaching to the transverse costal facet, and then eventually landing. The head of the rib would land on the superior costal facet. So these are the two articulation points that we see for the ribs in T1 through T12. When we get into the lower lumbar spine, we notice the main difference is going to be in the size of the body due to the immense amount of increase in load that the body or the spine has to carry. The first thing that we see is going to be that the body has become enlarged to support the weight. We also notice that the vertebral foramen has narrowed at this point, and it's called a cauda equina, or horse's tail. At this point, the spinal cord does not resemble a natural cord. It actually resembles more of a horse's tail at this type. So the spine isn't completely encapsulated in a spinal cord. We see the transverse processes again and the spinous processes. They become a little bit shorter in this region, and these are important for the attachments of specific muscles, specifically related to the upper postural effects. So the next part we'll talk is just the difference between a normal curve, a kyphotic curve, a lumbar kyphosis, and what we tend to classify as scoliosis. So this first illustration here is supposed to be normal. So this one, and when we did a lot of assessment, the meatus of the ear should be stacked over the shoulder and then should go straight down through the femur. And we see how the head is positioned at the breaking point. So the posterior or posterior curve, the concave aspect of the anterior of this, or the posterior curve of the cervical spine is going to find the change in the curve around C7. And then we're going to go straight down through the line, and the level about T12 and L1 is where we see the curve change. So about the level of T12, we start getting into the lumbar curve again, and then we can see how the lumbar curve has a concave shape in the posterior position. So we see the line or the position of the head going through C7 and T1, through T12, L5, and eventually coming through the middle, or what we consider to be your center of gravity. So this would be all the classifications that we're looking for a normal spinal curve. The second one is referring to a lordosis, where we see, and I'll draw a line down here, this lordotic curve means that we're increasing the posterior concavity of the lumbar, and we also can see it occurring up into the cervical regions. So we just see this increase of posterior concave curve in both of these regions. Number 3 is going to represent kyphotic or kyphosis. What we see is, again, a couple of things that are occurring. The main thing with kyphosis is predominantly affects the upper thoracic. And with the upper thoracic, what we see is this increase anterior concavity of the thoracic. And we also see the forward head position. So this exacerbates the forward head position. This will also directly affect the center of gravity. So when the head is forward, then we've discussed this, that the center of gravity will slightly shift forward also. And finally, the last one we have is scoliosis. This is just simply any type of lateral curvatures that can occur, or any sideways deviations. So we can see multiple things when we're looking at individuals with scoliosis. We could have a classic curving and slightly twisting of the vertebral column. It could occur, in this case, in the thoracic region. We could also have what is considered to be like a sideways deviation, where the spine is shifted over. In any effect, it can occur from cervical all the way down into the lumbar. And also, what we find is that anything affecting the thoracic region will then directly affect the position of the rib cage. When we're looking at the ribs, the first area that we should do is just classify these by their name and how they attach to the sternum. When we're looking at ribs 1 through 7, we consider to be these to be the true rib. And they're a true rib because they have their own costal cartilages. So where I'm drawing the lines here, this is where the costal cartilage will begin, and it'll attach to the various positions of the sternum. So the upper portion of the sternum is called the manubrium, the middle portion is called the body, and the inferior portion is considered to be called the xiphoid process. Each one of these, including number 7, has its own costal cartilage. So each one of these are going to be directly connected. This is also an important area because this is where we see the attachment of the diaphragm begin, is through the beginnings of rib 7. The false ribs, we call these false ribs 8, 9, and 10, is because each one of these is going to share its own individual costal cartilage that connects into the lower aspect around the xiphoid process of the sternum. And then the floating ribs, finally 11 and 12, you can see here that they do not connect anywhere into the anterior aspect of the sternum. And with that also, their main job is for protection. So they're located in the posterior compartment, and we are protecting essentially the kidneys that sit further into the posterior department. So as I mentioned earlier, there's 2 connection points to where we see the head entering into the vertebral column, or how the ribs attach. We see that the head can connect to the body. It can also connect to the costal facet on the transverse processes. And the distance from the head to the connection of the tubercle, or where the tubercle meets the facet or facet, we call this region the neck region. And then as we go towards the anterior end, from this point forward, this would be considered to be the costal cartilage. So this is what's actually going to be connecting to the sternum. So when we get into the aspects of the different types of ligaments, each one is going to have their own specialization. The first thing that we have to remember is that these are each vertebral column has the ability to slide. We call this the articular cartilages. And these articular cartilages, of how they're sitting on top of each other, is we see the superior articular process and the inferior articular process. And these processes are where we see the superior and the inferior and the superior connection between the two vertebrae. It is formed with a synovial cavity, and it has a semi-loose joint capsule to it to allow for this sideways motion that's shown down in the base of this slide. So they do have the ability to articulate with each other. But their main job is to protect the spinal cord. And what we're going to be looking at first is going to be all the ligamentous type features. So when we're looking at the ligamentous type features, they're all going to be specialized with a particular job. So the first one we would look at is the front. This is the anterior longitudinal ligament. And this anterior longitudinal ligament runs the entire length of the spine from the base of the skull to the sacrum. It's basically attaching to the anterior surface of each of the vertebrae and runs from the axis all the way again to the sacrum. Its main job is to primarily stabilize the spine, and it limits hyperextension of the vertebral column. And hyperextension would protect these intervertebral discs. So the anterior and posterior longitudinal ligament work together, and the posterior longitudinal ligament has two jobs. It forms or helps encapsulate the intervertebral disc, and it also forms the posterior surface of where the spinal cord is going to run through. So with the posterior longitudinal ligament, its job is very simply to maintain the integrity of the disc and to provide a space for the spinal cord to run. The next one would be the ligamentum flavum. So we can see it here and here. And the ligamentum flavum binds the lamina of each adjacent vertebrae, and the lamina is just that distinct point between the transverse processes. And it is considered the strongest spinal ligament. It's composed primarily of elastin tissue, and this elastin tissue forms the function, which is to protect the spinal cord and the spinal nerves that are coming out in a transverse position out of the spinal cord. The next one is the interspinous ligament. We can see it here. It has a little bit of an oblique look to it as far as the fiber types. And the interspinous ligament connects each one of the spinous processes. The interspinous ligament, its job is to become tight or taut during flexion. So it helps stabilize the position of the spinal cord. The next one, the supraspinous ligament. This supraspinous ligament connects the tips of each of the spinous processes. So again, it's running in the vertical back portion of the spinous processes. It's thicker, it gets thicker and broader as the ligament goes down towards the lumbar region. And this one is going to limit any type of hyperflexion that may occur in the spine. So when we're looking at the intervertebral discs, the first thing is their composition. So their composition we can see first is the annulus fibrosus, which forms this concentric ring. So the annulus fibrosus has a more of a stronger connective tissue look to it. And then the nucleus pulposus, which is located in the inside, is more of a gelatinous, pulpy substance, but their main job is to protect against compression. And the compression that occurs through walking or through gravity will push down through the pulposus, and this elastic or kind of connective tissue will prevent the disc from bulging out. So basically, as we become older, this area becomes more susceptible or less resilient. It's more susceptible to injury, or if we are improperly using it. And it can form two different types of injuries. You could first have a bulging disc, which usually means that when we have a bulging disc, the bulging disc would be the less severe, and the main part about any of the disc is going to be the spinal nerve that's coming out. So the spinal nerve is what is greatly going to be affected by either a herniated disc or a bulging disc. So a bulging disc may be pushing lightly into the spinal nerve, maybe causing some numbness. Or as the disc weakens, a herniated disc would mean that the pulposus has pushed out around the elastin or elastic type of connective tissue and prevent, and if it does hit the spinal nerve, it's a more serious injury. Bulging disc can be corrected by reducing muscle tension, so allowing for the compression that's occurring on the invertebral disc to become lessened. But once it hits the herniated disc and it's affecting the spinal root, then we could see weakness in the lower extremities or loss of sensation. At that point, our only option would be surgery. And that concludes the lecture for part 1 of the spine.